Good afternoon. My name's Julia Chisholm. I'm a consultant paediatric oncologist at the Royal Marsden Hospital, and I'm leading on the relapse part of the FaRRMS study. Dr. Michaela Casanova is leading on the regorafenib arm, and Dr. Suzanne Gatz is leading on the biomarker work that we've done as part of this study. The prognosis of relapsed rhabdomyosarcoma is poor. We know from North American data that only 17% of patients will be alive 5 years after relapse of rhabdomyosarcoma. If the rhabdomyosarcoma is localized at first presentation, around 36% of patients will be alive at 4 years, as shown in the chart here. And we know there are a number of features that make the chance of survival poorer. These include an early relapse within 18 months of diagnosis, prior radiotherapy, having had at least 3 chemotherapy drugs as first-line treatment, and a relapse that has spread or metastatic. We also know that for patients who present with rhabdomyosarcoma that spread, few of them survive after relapse, and we desperately need new treatments for these patients. You've already heard about vincristine and irinotecan in rhabdomyosarcoma. This is an active combination that's been shown in what we call window studies in newly diagnosed metastatic rhabdomyosarcoma, where 70% of patients were responders. In the relapse setting, around 30% of patients will respond. One study checked out 2 different schedules, a 5-day and a 10-day schedule. The response rate was not significantly different between them, and so the 5-day schedule has been taken forward in common usage in a number of different tumor types. And we chose this as a backbone for our previous relapse study in EPSSG, the VIT-0910 study. And when we started that, irinotecan was not being used as a first-line agent for rhabdomyosarcoma in Europe. The results are just summarized here. On the right-hand side, you can see the overall survival of patients with time from starting treatment, and those receiving 3 drugs, vincristine and irinotecan with temozolomide, had improved overall survival compared to those receiving vincristine and irinotecan alone, and that was statistically significant. There was a slight improvement in event-free survival or progression-free survival, as you can see in this chart, but it was not statistically significant. There was an improvement in response rate, and importantly, the 3-drug combination VIT was tolerable. There was a bit more toxicity, but not significantly more, and it was tolerable, but probably not tolerable with a further drug added. So now I want to tell you about regorafenib, which is a new and promising targeted agent that we are going to be taking forward in the FaRRMS relapse study going forward. So this targets a number of tyrosine kinases and has a distinct profile that targets blood vessel growth, angiogenesis, the stroma, that's the background that the tumor sort of sits in, if you like, and also targets the oncogenic properties of tumor cells. And this was tested in a phase 1 study, a dose-finding study in recurrent refractory pediatric solid tumors that included 3 rhabdomyosarcoma patients. And slightly surprisingly, because of the heavy pretreatment, 1 had a transient response to treatment and 1 had disease stabilization, which made us prick up our ears and think it might be an interesting drug to take forward. We knew from that phase 1 study what dose to take forward into a phase 2 efficacy study, and we saw that there was quite a bit of hematological toxicity. The schedule that was used was 3 weeks of treatment, followed by 1 week off with no other chemotherapy drugs. So to take it forward, we wanted to combine it with chemotherapy. And in order to do that, Bayer, which is a manufacturer of regorafenib, had to request a modification of their agreed pediatric investigation plan. That's something that's agreed with the European Medicines Agency as part of the data required for licensing of the drug in Europe. So in this phase 1b extension, the plan was to test 2 different dose levels of regorafenib in combination with irinotecan and vincristine, either given as a what we call a concomitant schedule, with regorafenib given in week 1 alongside vincristine and irinotecan, also given in week 2 and then a week off, or a sequential schedule where vincristine and irinotecan was given in week 1 and regorafenib in weeks 2 and weeks 3. That study recruited 21 patients, 12 had rhabdomyosarcoma. We found the concomitant schedule was too toxic, but 19 patients received a sequential schedule. We found hematological toxicity, blood count toxicities, and raised liver function tests as expected. And we needed to reduce the dose of irinotecan in a number of patients. We were able to define the recommended phase 2 dose of regorafenib as 82 milligrams per meter squared in the sequential schedule. So that brings us to the relapse part of the current FaRRMS study, where the plan is to test vincristine, irinotecan, and regorafenib against the standard of care, vincristine, irinotecan, and temozolomide. This is a randomized study, and the primary objective is to determine whether new systemic therapy regimens improve event-free survival in relapsed rhabdomyosarcoma. And the first new regimen to be tested is regorafenib. This will be given as a tablet or granules on days 8 to 21 of a 21-day schedule, with vincristine irinotecan on days 1 to 5, and then vincristine on day 8. This is a seamless phase 2, phase 3 design, so that's a multi-stage design. The first part has 130 patients to recruit, the second 260. And what we're looking for is a 15% absolute improvement in 1 year event-free survival. So no disease relapse or progression within a year. So 30% is standard, so we're looking for an increase to 45%. And that would equate to a hazard ratio of 0.66. And at least 70% of the patients must be under the age of 18, because this is data for Bayer's Paediatric Investigation Plan. So in terms of evaluation, we're going to strongly encourage biopsy at relapse. There'll be a response assessment with scans every 2 to 3 cycles. We'll be undertaking quality of life studies, a taste and palatability questionnaire for the regorafenib, blood samples from young patients for pharmacokinetics, and also and importantly, some biomarker samples. And Suzanne Gatz has worked really hard to try and get the biomarker work agreed, and that has been agreed with Bayer, who are also funding this along with the other aspects of the regorafenib part of the study. So we'll be looking at a form of MRI scans called diffusion-weighted imaging. There's an imaging biomarker to see whether that response on diffusion-weighted MRI correlates with outcomes. We'll be undertaking a number of different forms of molecular biomarker work on fixed tissue. So mRNA signature and customized analysis of genes of interest, whole exome sequencing for looking for mutations in genes, an RNA fusion panel looking for the common fusions and rare fusions in rhabdomyosarcoma, and a whole exome sequencing on germline blood to give us the constitutional DNA. And this will help us to, in the future, to see if there's any signature about which patients respond to regorafenib, even which patients respond to standard vincristine, irinotecan, and temozolomide, and will be a resource for a number of different research investigations in the future. And then additionally, we're going to take blood samples, plasma samples, to look for circulating tumor DNA to see whether that's a good measure of response to treatment and disease coming back. So the final contract with Bayer for this was signed in April 2021, and that included all the costs of the regorafenib part of the study and the biomarkers. We've submitted a no-cost extension to Cancer Research UK, our main funder, and we're in the process of submitting a substantial amendment to the Research Ethics Committee to get this approval for the inclusion of the relapse study. And it's anticipated to open early next year, possibly at the end of this year, but more likely early next year. So we're really excited about having a new drug to bring into the relapse setting, and we hope this will be a model for taking forward. We can bring other new drugs in frontline and relapse in the future. Thank you for listening.